we're having evidence now that BMI, an increase in BMI is directly associated with a reduction in grey matter volume.
Mm.
We cannot ignore that. We can't ignore that in this population, especially because this population of people have extra challenges. I mean, the general population, we live in an obesogenic environment. It's not people's fault if they're overweight or obese. It's difficult. It's difficult for everybody,
Mm.
but there's a lot they can do about it.
Yep.
So while there's not fault there, you can take the power and you can move to a healthier body weight. And thinking about the extra challenges being maybe reduced mobility, maybe being wheelchair bound, maybe a history of steroid use, maybe antidepressants as well, very common in this population. And all of those are things that we know to contribute to excess body weight. So it can be quite difficult.
From a dietary perspective, again, I keep talking about this toolbox, which sounds like this magical box of wonders that we can help patients with, which essentially it is. But through our training in dietetics, we're trained through what's called the nutrition care process. And I think it's really important. And I started my presentation yesterday by explaining that to the doctors in the room and the non-dietitian experts, as people aren't aware of our process. I think it might be a stereotype that people may present to us in clinic and a patient sits down in front of us and from the get-go we're talking about diet and how can we help with diet, and it's all from this dietary perspective. But our dietary assessment, what we call it, is very in-depth and very detailed. So for the first 60 minutes of a conversation, we're collecting things like anthropometry, biochemistry, symptoms that may impact someone's ability to chew and swallow or get adequate energy intake in. And then we go on to diet as kind of the last add-on. So without that big picture of how someone is presenting to us, the key role of what we do is we prescribe something that is tailored
Individualized care.
and individualized. Exactly.
It's not surprising that medical practitioners are likely to think about pharmacological interventions for things like those metabolic comorbidities because that's their training. It's completely understandable, but there is so much more we can give them as dietitians. And the things that we can give them relate to empowering people to accumulate those healthy habits for the rest of their life, because often people don't know how to go about doing that. They don't have the strategies. So it's not just the theory that we give them. I mean, often on the information sheets that patients are given, the theory's there, but not how to actually do it, and not how to actually do it in that person's life.
Yeah.
So a nutrition prescription, it sounds terrible actually, because yes, it's a thing, but it's more of a partnership when it comes down to it. It's more thinking about shared goals, agreeing goals, negotiating goals with the person that's sitting in front of us, rather than a top-down prescription. But we will call it that anyway. Nutrition prescription is different to a pharmacological prescription. We cannot expect a certain degree of adherence like we can with medicines. And that's because nutrition involves behavior change. It's not as easy as taking a pill. It's really, really hard. And we, as dietitians, don't typically try to change everything in the first consult. We might agree one or two things to start with and really help that person make that behavior change. And once that's established, then they come back and we work on a little bit more. And that's why Olivia's been seeing her patient for 16 months.
Yeah. And sometimes the actual diagnosis, if we get back to the process of nutrition care, the diagnosis might be that that patient is not ready for change. And that's really common, that it might be, like I've had experienced patients present to me in private practice, and it's purely my neurologist told me to come, or my GP or a family member begged me to be here because I've got fecal incontinence, for example, and I need support. But that patient is not ready to take on any information. They're not ready for change. So their diagnosis in that point is they might not be ready. So that's a huge part of this whole behavior change process. To be able to make long-lasting impact, the patient has to be ready for it. It's a huge lifestyle change in most cases, and some people are not in the right mindset. So it establishes a great need to, again, advocate for our role and get the whole medical team on board so they can be hearing that same message. I love the saying, speaking from the same language.
Yeah.
So the whole medical team, we're advocates for it. We all must be speaking from the same language, and to get that person on board and get the trust from that patient is really important.